Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
And now, a word from our sponsor. Did you know that sport helmets are rated on a 5-star system similar to cars? And the safest helmets have nothing to do with price, brand, or availability? Since 2011, Virginia Tech researchers have been providing unbiased helmet ratings that allow consumers to make informed decisions when purchasing helmets. The helmet ratings are the culmination of over a decade of research identifying which helmets best reduce concussion risk. This work is done as part of Virginia Tech's service mission and is 100% independent of any funding or influence from helmet manufacturers. Our mission at Concussion Corner is to expose you, the listener, to trusted spaces in the concussion arena that translate to clinic next day. Please visit the Virginia Tech Helmet Lab website in our show notes or at bit.ly/Virginia Tech Helmets and spread the word to aid in lowering concussion risk in your community. Thank you for tuning in, and let's begin the show. Welcome to Season 4 of Concussion Corner. My name is Dr. Jessica Schwartz, and I'm thrilled to have Dr. Kelsey Bryk with us today. Dr. Bryk is a proud Canadian who recently completed her PhD at the University of Delaware. She has been interested in the brain since she was 16, but became interested in concussions after watching professional hockey and suffering from a few concussions playing soccer. She subsequently went on to complete a bachelor's with honors and a master's on concussion research. Her dissertation research examined the neurophysiological health of adults over the age of 25 who suffer from persistent concussion symptoms by using various high-tech and clinically feasible objective measures. Kelsey, welcome to the Concussion Corner podcast.
Thank you for having me.
It's a pleasure. It's March and it's Brain Injury Awareness Month. And, I'm super pumped to be highlighting young and upcoming researchers like yourself because you're really selfishly answering the questions that I am interested in, but also really, bringing questions to light to the general public, which may not be so general, but hopefully we can get this information out to as many people as possible clinically, just about really important questions that are important in terms of clinical care and caring for people as person first. So I really appreciate what you've been doing in your young career.
Thank you.
So, I know you're in Canada. I know you're out of Delaware now. I hear it's -40 by you. How is how does one even start the car? That's my primary question.
That's a fair question. So this might confuse a lot of listeners, but we plug in our cars. We do not drive electric cars. We have block heaters that keep things warm. And so they actually start. A lot of people, I think, have synthetic oil here too, which also helps the whole starting in -40 thing. But if you're driving around Winnipeg around now, you'll see a lot of cars plugged in.
Wow, I didn't even know that existed. I know I've been in -27 was the coldest I've been in, and I can't imagine it being colder than that. So
a lot of layers.
Yes, kudos to all the layers and synthetic thermals. I'm sure you guys are rocking as well. Okay, so let's kick it off. So just so our listeners kind of key into, I was kind of exposed to Kelsey because I and now Dr. Bryk that through a few colleagues of mine on social media, and I saw that that she completed her dissertation recently and defended it 5-star, and I was like, wow, look at the topic here, and it completely locked me in to you and your work, and I'm so glad that we got to speak a little bit before you came on the podcast. But again, the language of even just seeing this in publication in terms of persistent concussion symptoms in adults over 25, there's not a lot out there. And I say this with all sincerity, and this is a place of only building up our colleagues and other clinicians out there. But historically in concussion research, if we haven't, and historically in medicine, quite frankly, in Western medicine, if we don't know what to do with a patient, we historically send them down two trajectories. One being we assume they're malingering and faking it, or we refer them to psych and think it's all in their head. And historically with this injury is that we found that there are somatic reasons for people behaving and feeling like crap, essentially. There's no other way, better way to put it in unclinical terms. But people do not feel well, and that changes their behavior. So whether it's the chicken or the egg, in terms of anxiety presentations or things like that, we've seen that historically with vestibular publications. And if you're a physio or OT like myself, or folks have gone through, this vestibular training, clinically, we see that all the time. So it's so nice to see folks like yourself trying to answer questions and dive a little deeper into what's potentially going on at a subclinical level and to things that we cannot see. So I'm really so happy to have you on, and really so excited to have the listeners kind of be a voyeur into our past conversations.
Yeah, for sure. Yeah, I totally agree with everything you just said. And, you briefly mentioned there's not much out there with the 25 plus age range. So that's kind of focused on the underdog for my dissertation and hopefully moving forward.
Yeah, I mean, in all fairness to other folks out there, people, it's also like when you go into a medical school program, physio, medicine, you want to work with kids and work in sports, right? So that's where a lot of our research is published out there, until you kind of see what else is going out there in the real world. So I know that you recruited 25 to 65-year-olds, and I say that for a reason, because when I work with folks 50 and over with closed head injury and concussion and MTBI, a lot of, especially women, a lot of clinicians, physicians at all, just assume it's hormonal, or it's early onset dementia, or menopausal, or, everything else under the sun, other than, have you checked for, the patient with a fractured hip? Yes, we triage the big nasty in the ER, and we have, an ORIF. However, did anybody look at the head, that they hit their head on the way down, or, vice versa? So, really important work. Let's highlight your work. We'll give a little bit of history, like we always do, for new interviewees. So I would love to kind of hear a little bit about your educational upbringing and kind of how you entreed into concussion.
Sure. Yeah. So this is kind of a funny story. So when I first got interested in the brain, just in general, I think I was like 15 or 16. It was in high school for sure. And it was actually because of a Grey's Anatomy episode. And so I can't remember which one. I'll try and look it up while we're talking. But
I always like to say, Kelsey, that Grey's Anatomy is my longest relationship. I've watched every episode, even when it was like not that great. So anyway, I digress.
Oh yeah, no, I watched it, when it first came out, loved it. I haven't watched it in a while, so that might be my post PhD plans, is to rewatch everything. But yeah, it was a Grey's Anatomy episode, and basically the gist of the episode, of this one story in the episode, was there's a dad who can't walk his daughter down the aisle because I believe he has Parkinson's. I think they do like a deep brain stimulation style treatment on him or something. And in the end, he does walk his daughter down the aisle. And so, I'm watching this at 15, 16. I'm like, whoa, did they really just do that to the brain? And the guy's fine. And, his tremors are not gone, but I guess maybe, just not there as much. Anyway, I watched this episode and I was like, that's so cool. I want to know more about the brain. So I started looking into it. That passion sort of stuck. That led me to go to do my bachelor's in a program called biopsychology, which, another word for neuroscience, essentially. I absolutely loved that program. I loved all of the psych classes, the bio classes, even some of the chemistry classes, because they, in some way, shape, or form, could always relate back to the brain. And that's what I found myself thinking throughout essentially all my undergrad courses, was, how does this relate back to the brain? And then I think probably maybe second or third year of undergrad, I was watching hockey, as us Canadians do. And it was the season where Sidney Crosby got 2 back-to-back concussions, and he was out for a really, really long time. And I think that raised a lot of questions and really brought concussion awareness to the forefront, because here's this, young, healthy, super popular, talented hockey player, and now he's out for a really long time because of an injury we can't see. And so that really kicked off my concussion interest. I just remember sitting there, even during that game, I grabbed my laptop, I'm Googling, like, what is a concussion? What do we do about a concussion? How do we fix them? Things like that, right? And so, that kind of led me down like, well, I have all these questions. What do I do about it? And so that's kind of where I shifted into sort of the research mode. And I didn't really know what to do about it in undergrad, because I'm like, okay, well, undergrad, you sit in lectures, you go to your labs, and you get your degree if you get the right grades. And then I realized that I think one of my friends who had already graduated or was just about to graduate the year before me was doing an honors thesis. Somehow I heard about that option. So I looked into it. Turns out there was a guy at my university who did concussion research. So I just kind of randomly reached out to him, and I knew him through the program as well, because he was in the biopsych program. So I reached out to him and said, like, hey, I'm really interested in concussions, but I don't even know where to start. I don't know the first thing about research. I just want to know more. Like, I'm just curious. And so he really helped me understand the process of research, just in general, as well as concussions. And of course that, an undergrad honors thesis, I collected data from a bunch of undergrads who reported their concussion history. I had them do a couple, simple, I think, reaction time tests on a computer, and that was that. And I just sort of, looked at the different number of concussions that people had reported. And that was really my first introduction to concussion research specifically. And so after I did that, I liked the project, but I wasn't satisfied enough, which sounds weird to say, but it really just, it brought up more questions that I had than it did answer any questions I had. And so I kind of brought this up to my honors thesis advisor one day and said, like, well, what do I do about this? I still have more questions. Like, that was cool, but now I don't want to know way more. And he was like, well, there's a whole world of research that you can go into. So he really introduced me to, not just research and the process of it, but also, potential careers and the path that I can take to stay in research. And so he said, well, think about doing a master's. It's typically a 2-year program. It's very research-based, way more research-based than, an undergrad thesis. And so I ended up moving out to the West Coast to do my master's out there with Dr. Paul Van Donkelaar. He's actually in Kelowna, which is about 4 hours inland from Vancouver. Did my master's there on repetitive head impacts, actually. So not concussion, but just looking at repetitive head impacts in football players who were about 18 to 25. They played for a local team. And I had them do some assessments pre and post season. And so that further got me into sort of the sport related concussion world. And which, of course, as you mentioned earlier, research has been so heavily focused in that area that I felt like I had a massive learning curve at that point. So that was a great introduction for me to actually really figure out what a lit review is and how to read papers and analyze them, and then the writing process as well. Luckily, my master's thesis was sort of a project that the lab had wanted to do. And I was just coming in as I love research. I'm interested in concussions. What can I do? And so that's how I got my master's thesis project. Then, I still had more questions than I did answers. Didn't really know what to do. Kind of throughout this whole process of undergrad and master's, I was thinking I still want to go to medical school. That was kind of the original thing that I wanted to do when I was an undergrad. And I sat down with my master's advisor one day and was like, well, what do I do? Because, all of the stuff that we're doing is cool. And I love research, but I've kind of always also wanted to go to medical school. So what do I do? And so there was an MD PhD actually in our lab where I did my master's, and we had a lot of good conversations about sort of the clinical side of things and the research side of things. And I remember talking to him one day, and he said, the way you think and the way that, just what you're describing you want to do, you should go do a PhD. And so I talked to my advisor more about it. And at this point, it was actually pretty late in the game for applications for PhD programs. So I just sort of put feelers out there. Around this time as well, I discovered the CARE Consortium. And I think it had just kicked off like maybe a year prior to this. So I was like, all right, this is cool. I don't think anything like this exists in Canada. This is, you know, a very US thing. So how do I get involved with it? So I found the email for the guy who's in charge of it, emailed him just out of the blue, said, hey, this is who I am. I'm just wrapping up my master's. I am willing to move anywhere in the States at this point. Like, this project seems so cool and I would love to be a part of it in some way, shape, or form. So he responded back to me, and he was at Michigan. So I talked to him about it a little bit. He was trying to get funding. Turns out he didn't get the funding to have me there. So I think he just, you know, passed my name out to everyone who was involved in the project and said, listen, there's this girl from Canada. She's just wrapping up her master's, wants to do a PhD. You know, is anyone looking for a PhD student that could be a part of the CARE project? So then my doctoral advisor reached out to me and said, you know, hey, we're looking for exactly that. And, you know, we had a Skype or a Zoom conversation or something within the week. And this was, I think, March or April. And, you know, a week or two later, he was like, yep, you can come to Delaware if you'd like. And I had no idea. Awesome. Yeah, I had no idea where Delaware was when
I was just going to say, because you pointed on a map.
Yeah. Oh, yeah. No, there was a point where I remember waking up, looking at my phone, seeing, you know, my advisor, Dr. Tom Buckley's name at udel.edu. And I'm like, what's UDel? University of Delaware. Okay, where is University of Delaware? So that was kind of funny. I had no idea where it was on the map, but
yeah, I mean, it is a nice place, you know, and it's cool because, you know, my residency was here at NYU in orthopedics, and we had, you know, two of your all-stars physios come down and PhDs, Greg Hicks and Tara Jo Manal, who's like one of my favorite professors ever. And she's repeatedly won, you know, Teacher of the Year or Professor of the Year award, you know, for obvious reasons. And I just remember our director of residency being like, you know, Kevin Weaver, Dr. Weaver, just being like, I want to be like her. And he's like a big guy, you know, with a bald head and a goatee that looks like he should be wearing, you know, on a motorcycle. And it's true. And it was like, after, you know, I met Tara Jo, it was just like, boom, you know, that's, you know, everything that you want to be as an educator. So, so that's awesome. So, you know, let's jump in and, you know, so I saw, you know, again, University of Delaware, UD concussion research tweet out the effects of persistent mild traumatic brain injury symptoms in the neurophysiological health of adults. And boom, your name was there, PhD candidate, and you successfully, you know, completed your dissertation defense. So, let's jump there and let's highlight you. We've got about 10-15 more minutes left of this podcast, and we'll continue into part two. But I really want to highlight, you know, why this topic kind of came into your purview and why you decided to tackle it, because it's not something that we hear about often. You know, up until 5, 10, 15, 20 years ago, this concept didn't really exist to the general population. And again, going back to when Sidney Crosby was hit, I looked up the timeline, and that was in January 2011. So he had back-to-back hits 4 days apart. And again, from a timeline perspective, again, we have to remember, you know, we've had Jeff Kutcher on multiple times, and, you know, Jeff Kutcher brought the terminology concussion to American Academy of Neurology, and it was kind of scoffed at initially. And again, 2004, I should say, and then 2008, you know, we had the whole cherry picking of data with the NFL on ESPN, and then this progression of conversations of concussion in the media, you know, and cherry picking data. So it's so important to kind of hear where this information is coming from literally the horse's mouth, from people who are doing the actual research. So I'm so happy to have you on, because again, hearing this title within the last 5 years is just unheard of. So I'm super pumped to have you on. And, you know, let's talk about first, again, we know your history, you know, with, you know, being drawn to the Sidney Crosby story, and we all are in this world. You know, how did you kind of come up with doing this, and was there any resistance, you know, to any of this research early on when you presented the topic, you know, after you figured out what you wanted to write about?
Yeah, I get asked this question a lot, and I can't really say that there's one specific moment that it sort of occurred to me I wanted to look at this population. But it was really just, I I kind of got sick and tired of hearing about the sport related, football concussion world, essentially. And you know, when you tell people that you are researching concussions, immediately people are like, oh, one time I had this concussion, or, oh, I know someone who's, 2 years out and they're still suffering symptoms. And you hear stories like that. And I actually love hearing those stories because it just kind of reinforces why I do what I do. And so I think it was just a collection over the years of hearing people sort of tell me their stories saying, oh, you're a concussion researcher. I had one 2 years ago, and I never had migraines before, and now I have a migraine once a week kind of thing, and it still won't go away, or something along those lines. And so I think that those stories just kind of added up in my head, and I started realizing these aren't people who fall into the 18 to 25-year-old category, nor do they play sports. I mean, most of the time they weren't getting their concussion or sustaining their concussion from sports. It was, falls or motor vehicle accidents, things like that. And so the more and more I heard these stories, the more I started thinking like, well, how do we assess these people? Because they're not 18 to 25-year-olds. They're not, football players who, have access to a team physician or an athletic trainer or whatever on the sidelines. Like, what do these people do? Because sometimes they go to the emergency department, sometimes they just don't, and they suck it up, or a week later they're finally going to their GP. So I think all of that just added up in my head, and I figured, okay, there's this chronic population of the general population 25 to 65 who they have families, they have jobs, they have kids to take care of. They're living their everyday life, and then it comes sometimes full stop with a brain injury. And alongside that, I mentioned this before, but it's an invisible injury. We don't see it on a brain scan, or, as of right now, I'm not aware of any blood tests that can assess for these things. So it's really just, you got to take the person's word for it, essentially.
And
And
then
so
it's
again,
also, concussion diagnosis is a clinical diagnosis only.
Yeah.
So it's, again, we go back to that old adage of like, well, wait a second, we haven't been traditionally trained in concussion. And I say this again, we only build people up, but again, formerly, neurologists in this country didn't have formal concussion training until 2015, which these are brain physicians. So how does this trickle down to other subpopulation, subspecialties and other clinical specialties? So yeah, and just connecting to this, what we're about to talk about and what you've kind of mentioned a little bit here is, you're an N of one hearing all of these stories. And again, so you can imagine folks that are in clinic treating patients, and clinicians just don't know what to do. And again, as someone who, has suffered and lives with persistent symptoms from my mild traumatic brain injury and concussion from 2013 car crash, where I was hit from behind by an unlicensed driver. I say during my own recovery, it's kind of twofold. As a patient, we don't have the subjective language to express the what and how we feel when we have a head injury. But on the other end of things is that because of that, if you're a skilled clinician, you will allow your patient to give you a detailed subjective. And oftentimes they will give you cues subjectively, whether they realize it or not, that of areas of that they're having functional deficits in. Are they having difficulty navigating a busy mall or supermarket, or remembering short-term things? They're going to give you some of the neurocognitive deficits and vestibular or ocular motor. They're going to give you a lot of the subjective language, and they don't realize it. But we have to be trained to know what we're looking at, so we know what we're looking for. So this is where we have this big disconnect between patients who have been not acutely concussed and who are living with persistent symptoms, and and then suffering through the healthcare system because often folks aren't trained here. So again, I mean, just super pumped, to have this conversation with you.
Yeah, for sure.
All right, so let's highlight. We'll take the next 5 minutes to highlight, kind of set up who the population was for this topic of effects of persistent MTBI, symptoms on the neurophysiological health of adults. Let's set up who the N was. Let's set up the range, and then we'll actually talk about the details of the study in part 2 of this podcast.
Sure. So my population was, I've mentioned it a couple times, but I had recruited 25 to 65-year-olds. And for the PCS patients, persistent symptoms patients, I had 15 adults, and then I had a control group as well, which was 24 adults. And basically, I think the one biggest point that I would highlight for these patients is that I didn't require the patients to have a diagnosis of post-concussion syndrome, because I'm sure we could spend hours talking about the different definitions and why there's no consensus on that. But I didn't require them to have that diagnosis, but I did require them to have a diagnosis of mild traumatic brain injury, physician diagnosed. And then I was recruiting from local physician clinics and physical therapy clinics. So it was sort of confirmed by the healthcare providers that these individuals were experiencing symptoms. And part of my dissertation was assessing their symptoms as well, just, a basic symptom questionnaire. So we were kind of able to confirm that. So I was really just trying to get at people who had a mild traumatic brain injury diagnosed, and that they were at least, I guess the other important point is they were at least 3 months prior, or 3 months since their concussion. So, I had a wide range. There was no upper limit. I think I ended up having someone who was 3 or 3.5 years since his injury. But they had to be at least 3 months, and
Yeah, and that's important for our listeners to kind of lean into. Again, if you're driving, don't lean, or if you're on the treadmill, stay put. But very, very. Oh gosh, I'm blanking on her name. Who wrote Lean In? Oh, Sheryl Sandberg. So Sheryl Sandberg asked, just lean into this information that Kelsey is giving to you, because two important parts there. We actually don't have a universal definition of traumatic brain injury, which, this is why we do not have phase 3 clinical trials that have completed in the last 30 years because of this lack of definition. So we've got to get on board there. And then also, throw another wrench into there. We do not have a definition of post-concussive syndrome. Kelsey and I, or persistent, symptoms of, after MTBI. Kelsey and I do both agree, and I love that she set this up of 3+ months there, because again, there isn't an agreement, and really whatever paper you're reading, you really do have to orient yourself to what the author's definition of said markers are, because again, we see 3 weeks sometimes. I'm like, that doesn't even make any sense, because for the neurophysiological, things are still happening neurophysiologically often at the cellular level, which we have seen in rat and mouse studies, and even human studies with Henry et al.'s paper in 2015, and so on and so forth. And even with the care consortium, right? We even see that at the NCAA level with, folks being out 14 to 21 days as opposed to 7 to 10 in that old 2002 study from, Berlioz and al. And it's so cool to actually see them going back to their own work, redefining things, and because we're able to define things and look at things with more clarity. So anyway, so I digress. So important to pay attention to definitions there. Kelsey's were persistent symptoms consisted of 3+ months. There was no upper limit. And again, you heard that somebody was there for with symptoms for 3 to 3.5 years. Myself, who's even 7 years out from my last major concussion, I still have persistent symptoms of, autonomic issues and ocular motor deficits, and sensitivity to certain lights, specifically LEDs, which again have nothing to do with brightness. I can be in the sun, I ride my bike, the whole thing. I've at, conference in Vegas or wherever. But if it's an LED overhead light and it's directly shining into my eyes, I cannot tolerate that. So it's kind of like my kryptonite. But again, I'm 7 years out. So we do need to normalize this conversation of having with people who are survivors of concussion or thrivers of, persistent symptoms, that people do live with persistent symptoms. And it does become almost like a diabetic management because it's this invisible injury. People look fine, but they may be suffering, at different times from some things that are somatic. So again, kudos to all of this. To finalize this podcast, so you recruited folks 25 to 65. They didn't need the concussion diagnosis, but they did the persistent PCS diagnosis, but they did need the MTBI diagnosis. And then you brought them in two separate days, 7 to 10 days within each other, correct?
Yes.
And what were the instruments that you used for your dissertation?
So one of the days it was kind of more of a high tech day, I guess. We brought them into a motion capture lab and had them do a bunch of dual task gait conditions. And so briefly, we had 4 different cognitive tasks, and then we were looking at not only how they walked in terms of like speed, step length, things like that, but we were also looking at how they initiated their gait. So we had them standing on force plates, and we do, I'd have them stand for 2 minutes, just get a quiet stance, normal balance. Then I'd have them walk a whole bunch, 2 different lengths, just walking, just see how they do that normally. Then they would, first before that, they would stand on the force plate and they would answer our 4 different cognitive tests, just standing to get like the single task cognitive condition. Then we do the single task walking, which I mentioned already, just walking normally. And then we throw it all together and see what happened when they had to walk and talk at the same time. So that was all in the motion capture lab. And that was essentially what one of the sessions was. And then I brought them back and did more clinical based stuff. So I adapted, because I was so heavily involved in the CARE consortium and very, very familiar with the testing protocol of that study. I adopted some of the assessments that I guess showed more promise in terms of assessing the chronic symptoms. So things like, the standardized assessment of concussion, or the BESS. There's lots of literature out there that says, it's great on the sidelines or within the first 48 to 72 hours, but after that, not so much. So I really sort of looked at, okay, has anything been used in the more chronic stage? Even if it was, like 4 weeks out, that was enough for me. So I took a couple of those tests and had my participants go through those clinical tests. And then we also actually used something.
What were those tests?
Sorry. Yeah, I guess I should mention that. We did the clinical reaction time. So just drop the stick, catch it as fast as you can. We did the King-Devic test, the VOMS, so vestibular ocular motor screening. And then we had an iPad version of the trail making test, part A and part B. And then after I had them come to, it was more of a high-tech lab, I guess. So it's a robotic technology called the KinArm. And a lot of research with this specific technology has been focused in the stroke population. There has been some work done with traumatic brain injury in general, and specifically mild traumatic brain injury. I think there's 1, maybe 2 papers that are on persistent concussion symptoms, but none that really just sort of characterized what was going on. And so this technology is basically, they're sitting in a big fancy robotic chair. The robot itself has arms that only move in, oh gosh, I'm blanking. Like a forward. It doesn't, your hands don't move up or down. They just move sort of forward or backward, and kind of around and in one plane essentially, or two planes.
And I can post what this is in the show notes too. We're not endorsing
Yeah,
anything,
for sure.
but again, I can show that because people can get the visual.
Oh yeah.
Again, when you're not driving, but you know, I know a lot of people listen to us on the way to and from work. So, but yeah, absolutely, I'll post something so they can actually get a visual of what this is, and we'll help them understand what you've done.
Perfect. Yeah, so we use the Kinarm. The technology itself comes with some just standard tasks that they've programmed. So I basically, and I had actually used this technology in my master's, so I was pretty familiar with it. So I looked at all the different standard assessments that were a part of it. And there are some where basically it's a more sort of motor-based task where it's just a simple sort of like one, for example, is just a reaction time test, or another one is use both hands. Your hands are paddles and you're hitting away as many things as you see on the screen. And then those tasks sort of had a more difficult version of them, or more cognitively challenging version. So I sort of took, 3 pairs of tests, the first half of the pair being more motor-based, the second half being the more cognitively challenging, and looked at sort of what was happening there, if that makes sense.
Indeed. So I'm going to actually, I'm going to pause us here because we're up on our 30 minutes, but I'm actually going to leave the listeners kind of on the edge of their seats we come up on part 2. But something I definitely want listeners to come in on here and really connect to are the 4 conditions that you use, in that motion capture lab on day 1, and thinking about you had them as you measured them for in quiet stance. You did a single task standing assessment. You did an ambulatory single task assessment, and then you added a dual tasking walk and talk cognitive physical assessment. For clinicians out there, I really want you to connect to why this is so important, and why Kelsey's work is so relevant to us in the clinic for knowledge translation purposes. So when we're thinking of, again, as clinicians, as doctors of anything in rehab, we think in short-term and long-term goal planning. And the same thing is kind of essentially what you broke down your dissertation to. In terms of, planning to rehab folks back. So we've done this historically with stroke, and actually we just come up on our 100 years a month or 2 ago for the American Physical Therapy Association, which I'm one of our spokeswomen for. And it was so cool to see that, we literally as physios have come out of a novel pandemic in 1918, just literally off the cusp of that. And really working with folks from World War I, as rehabilitative aids is what we were initially called. So thinking in terms of, we were working with brain injured patients literally from day 1 as physios, and we've been prescribing and rehabbing folks, thinking in short-term, long-term goals in terms of that, and then the progression of their rehab is exactly in how you set yourself up into, okay, we have to progress from single task to dual task, challenging cognition and things like that, because our neuropsychology friends and colleagues, they have a lovely time, 60, 90 minutes, sometimes 4 days, 6 hours, whole day assessments of people. But again, a lot of times they're not dual tasking folks from a motor planning and a cognition aspect. So it's so lovely to see you looking at literally the patient is 360. So I'm really excited to kind of key our listeners into part 2 of this episode with all your results and what you found. But again, just the setup of your dissertation was had so much clarity and necessary evidence here for us, because again, this is going to translate into clinic. So really well done so far.
Thank you.
Okay. So how do folks find you, Kelsey? What's the best way for folks to find you on social media, and, if they want to reach out?
So I'm pretty active on LinkedIn and Twitter. My LinkedIn is just under my full name. And
it's Bryk, Bryk, pretty awesome.
Yes. Yeah. And then a play on my last name. My Twitter handle is She's a Brick House.
Yes, well done. You have won so far you have won the best handle of Concussion Corner Award.
Excellent.
So we'll put all the links in the show notes to Kelsey's LinkedIn and her Twitter. link She's a Brick House, spelled BRYK. And yeah, I'm looking forward to recording part 2 with you. Thanks so much for coming on Concussion Corner.
Thank you again.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.